Some people just need a bit of reassurance that they're not weirdos or freaks or abnormal in some way. You know, at the end of the day, it's about reframing things sometimes, isn't it? And looking at, what are the causes for this? Is this just me, or is it the medication?
Are you still thinking about sex? Well, if you are, it's a good thing, because this week is part 2 of 2, all about the sex lives of people who have an epilepsy, common challenges faced, and solutions to those problems, all with the cool, ultra approachable epilepsy specialist nurse with whom you can talk to about anything, Jenny Edwards. If you're new and you haven't done so already, please do like and comment on this episode and subscribe to our channel so that we can get more people learning about and developing a factual understanding of the epilepsies.
I'm Jenny. I'm one of the epilepsy nurses in Swansea Bay Health Board. I work in a team of 3 epilepsy specialist nurses in the southwest of Wales.
From the patient perspective, if they spoke to you like, oh, I can't stop taking this medication because of my seizures, or because I will have a seizure during sex, but then I am struggling to now get an erection or be ready for sex, or get moisture in one's vagina because of it, you know, is there hope?
There's always hope. There's always hope. And the first step is talking about it, because I might not have the answers, but I'll really try hard to find out, you know. And I think, you know, I've spoken to some of the neurologists about this, past and present, that I've worked with, and we've been in some really interesting conversations with patients about how we can move forward. So the ones who are able to be really honest about it and say, I really need help here, you know, they're the ones you can kind of go, right, what can we do? And then, you know, they're open to basically any suggestions. And that could be things like taking a bit of Viagra, perhaps. You know, it could be the answer for some people. The answer for other people may be thinking about the other medications they're taking. You know, how can we better manage that? Are there certain medications that wouldn't have the flattening effect that antidepressants can sometimes have, or, you know, the
Excuse
issues?
Me, but I like the word the flattening. So
I didn't think of it.
I'm so mature. Sorry, carry on.
I'm just as bad. It's fine. But, you know, it's about looking at the bigger picture, seeing what we can do. Is it that, you know, is there something you could introduce into your sex life that would be more stimulating or help you feel more relaxed and more able to kind of enjoy the process?
Yeah.
You know, that could mean anything, couldn't it? It may mean having conversations with your partner, maybe planning through the day, you know, maybe some text exchanges. I don't know. That's
like, darling, ding dong, we want to make this a little bit better.
Yeah. You know, how do you spice it up, really? And
again, that's assuming one has a partner.
Yes,
not if somebody you don't know.
And you might not. And it might be just about, you know, being able to masturbate happily without thinking, oh, God, you know, my mum's going to have to come in because I'm going to have a seizure at the end of this. Can you imagine? I mean,
or it takes longer because, and then if it takes longer, you'll get worried that it's taking longer, and then it's not going to happen.
I'm frustrated and angry, and, you know, what's the point?
Yeah. What do you think also about making people just generally feel better about themselves? Because I think that can be really important, especially if you're in this situation. I was just thinking of exercise, for instance, can bring a lot of more positivity and just maybe more confidence to some people.
100%. Yeah. I think it's about finding the joy in life, isn't it, in general? I think if you can find joyous things that you love, it's not all about sex, of course, although it's really important. You know, if the other aspects of your life are better, then, you know, things will improve. And I'm a great supporter of people having antidepressants, you know, if they need them, especially with epilepsy. They're 3 times more likely than other folk to, you know, struggle with mood and anxiety. So unless we treat those things, so we know they're triggers for seizures as well, then things can get worse all round. But it shouldn't just be about the antidepressant, should it? It's got to be the whole picture, you know. Talking to people, maybe having some supportive counselling. We're very fortunate in Wales that we've got Epilepsy Action who provide counselling to our patients, and it is fantastic. And the feedback we've had is brilliant. We've had people ask if they can have more sessions, you know.
Oh, really?
Yeah.
Great.
Yeah.
Yeah. And I think there are actually more opportunities out there for things like that. It's just that generally we don't know about them. So I'd say do reach out to your epilepsy nurse or your neurologist, epileptologist, or just Google it. There are some therapists out there, and not everyone charges. Like with Epilepsy Action, it's free, right?
It is free. And, you know, we've also, and I'm not sure about the situation in England, but we've also got access to online CBT, which is really good through Silver Cloud. So anyone in Wales can access Silver Cloud, which is really helpful as well. I'm sure he wouldn't mind me saying my partner doesn't have epilepsy, but he has access to Silver Cloud when he was struggling with some anxiety and low mood. And he was like, it's great. And he's a big burly carpenter, you know. He's not the type you'd think, oh yeah, he'd be down for counselling.
But that's like anyone that can benefit from counselling. It doesn't matter, male, female, in between, you know, or whatever your background, it can, and not all. The first type of counselling doesn't always work, and that's fine, right? Or if you see a counsellor, you might not click, and that's fine, but there will be somebody out there and a type of therapy that can help you. Just don't give up.
No, never give up. And for some of our patients, I think it's fair to say that it's the epilepsy nurse who's the one who they feel safest talking to. And we, you know, if we can help, we will. You know, we're very honest about our limitations around those things. But I mean, myself and one of the other nurses in our team, we've both got a mental health background.
Okay.
You know, so that does give us a little bit of maybe insight and, you know, perhaps think about things in a slightly different way. More
empathetic way, I think, not just from certainly not a judgmental way, and not necessarily even a diagnostic way, but you're empathetic.
Yeah. And it's sometimes the best thing you do is just listen, isn't it?
Oh, completely. I used to have an epilepsy nurse, and she was just wonderful. We have, they're not all female, right? So we have people of all sexes, and and they were just really lovely. I felt I could just open up to them, and there was less of a time limit on how long I had with them. And it's almost like you guys are kind of counsellors yourselves, really.
Yeah, it does feel like that is a big part of the role, whether it's, you know, official or not. And, you know, and I think it all comes down to trust. And one of the things we found in our team is that some people will ask for one of us by name because they feel a bit safer, perhaps, and that's fine too. I don't mind that, you know. And we've there's three of us, so we can kind of, you know, say, "Oh, so and so rang for you. Will you give them a ring?"
And it's not offensive to anybody. It's just who you click with.
Yes, and that's normal, I think.
So, Jenny, the idea of normality bores me, I say, but a lot of people with an epilepsy, and often other morbidities that can come with it, feel like a bit of a freak. They are abnormal, and that can be isolating for them. I think epilepsy nurses can really help with that. What do you say?
Yeah, I completely agree. I think some people just need a bit of reassurance that they're not weirdos or freaks or abnormal in some way. Because, you know, at the end of the day, it's about reframing things sometimes, isn't it? And looking at, what are the causes for this? Is this just me, or is it the medication, or is it a combination of my condition, the medication, and me? You know, whatever it may be. But just knowing it's okay to kind of talk about it and find out together, because that's a big part of our role is going on a journey with someone and getting the answers for them. And we can't always get the answers, but we can find solutions.
Yeah.
You know? It's like having a diagnosis of epilepsy, isn't it? And I know that's something you were really keen on, you know, raising awareness about, is it's not just epilepsy, it's the epilepsies. And they're all different. And, you know, temporal lobe epilepsy may more affect your sexual health and your mental health.
And why is that?
I'm not entirely sure, and I'm going to have a good look at this, actually, and I'm going to speak with Owen and Rob about what their thoughts are about it, because it's something I came across today when I was having a little look through, you know, Lamotrigine, things like this being useful. And it was something that came up. The temporal lobe epilepsy apparently can affect your sexual function more so than other types of epilepsies.
Which is a real bugger, isn't it? Because it's the most common type of epilepsy too.
Yes, and your memory's affected. And I'm like, so,
Yeah.
oh, great, that's another one to add to the list then, you know. And
Great.
Yay!
Not that I'm saying people don't experience these things necessarily with other epilepsies. It's just more common in the temporal lobe epilepsies. If people know that, okay, first, the most common type of epilepsy, and it's so much more common in people with temporal lobe epilepsy. That's a few million people that are affected by very similar, if not identical symptoms as you, which includes sexual dysfunction. I don't know if we even like that term, but problems basically having sex or a shag or whatever you want to call it.
And it makes you miserable. You know, if something makes you miserable, we've got to find ways of you not being so miserable and helping you not be so miserable. You know, and that can look like any number of things for each person, can't it? And I think the relationship between the epilepsy nurse and the patient is really crucial. If you haven't got trust, you're not going to move forward with any of these things at the end of the day, you know.
For people that don't have an epilepsy nurse, which is the majority of people in the world, how would you propose bringing it up? A patient bringing it up, and how would you propose the clinician bringing it up?
That's the $1 million question for me, I think. I always try and look for ins. So I try and, you know, if, say, a male patient is on valproate, we've got an in there, you know, because we have to talk about the potential for babies, you know, having malformations, should they conceive when they're taking valproate, or should their partner conceive when they're taking valproate. So you've kind of gone in to talk about sex then and say, you know, how are things? And, you know, most men would probably like clam up if you just said, so how are things in the bedroom? You can't just go in with a question like that. That's just, you'd just be like, why are you asking me this?
Although to be fair, loads of women would too. They'd be like, I can't believe you're just asking me that. Especially if they're not prepared, right?
Yes.
So sometimes it might take more than one appointment to get in there.
Yeah, that's what I feel about, you know, having that kind of relationship, building trust, and also, and knowing, because one of the most important things I think we say in appointments is, look, you've got open access. That really does mean open access. And I have patients who ring me every week. I have patients who email 2 or 3 times a week. But that changes depending on the need. So, you know, if they'll have times where I'll get 4 or 5 emails in a day, and we'll have a little bit of a conversation, you know, and other times I won't hear from them for a year and a half because everything's going well. But, you know,
which is good.
Yeah, they know I'm there when they need me. So it might be a year and a half, but I'll still answer, you know, when they email. So building trust is super important. I think some people are just more open and maybe feel it's a more important thing to discuss, maybe for them. Other people don't want to embarrass us. And I just want to say, please don't worry about that. There's nothing I haven't heard, I promise. There's probably, I long for the day for people to ask me a question I haven't been asked before, because, you know, we thrive on that.
I bet. But what would you say, though, for when people don't have you? What happens? What are the tips?
Have you got a good relationship with the neurologist? If not, do you have a good relationship with the GP? If it was me, I think I would probably make an appointment with a practice nurse if it was something that I thought needed, you know, a clinical.
The GP practice nurse.
Yeah, because my own experience with talking with the GP is very often they don't remember me from the last time they saw me, you know, or it may be a locum, and they're all very good, and, you know, no criticism there. But the GP practice nurse, they've got a bit more time, a bit like us. If you haven't got an epilepsy nurse, maybe you could say, look, you know, I need some help. I don't know where to go with this. They're easier to talk to, more approachable.
There are some lovely GPs, but yes, I think I think the nurses are often more trained to listen for longer and
active listening, isn't it?
Yes.
You know?
Yes. Thank you so very much, Jenny. This has been great. I love that you're so open talking about these things, because these things are so crucial to the animals that we are and our quality of life. And, you know, I don't know if as a species we'll be embarrassed about talking about them forever, maybe, because, oh my goodness, it's one's bits, one's genitals. But hope, but knowing that there are others there that we can talk to, take us seriously, who don't laugh at us, that's really important. And knowing that we're not alone, and shouldn't be ashamed for talking about and seeking help for issues with sex. That's what we need. So thank you.
100%. I don't want anyone to have their life ruined because of something they can't feel comfortable talking about, If we can help, we should.
Again, thank you so much to Jenny. These are real, very common sexual challenges faced by people with an epilepsy, and well, actually people without an epilepsy as well, and their partners. And so it's great to know that there's hope and even solutions out there. Do learn more about Jenny and her work on the website torierobinson.com, where you can access this podcast, the video and the transcription of the entire episode, all in one place. And if you're new and you haven't done so already, please do like and comment on this episode and subscribe to our channel so that we can get way more people around the world learning about and having a better, actually a factual understanding of the epilepsies. See you next week.